Hi,
Hi,
good afternoon, everybody.
I'm Dr. V.
I'm Dr. Horn.
We're going to talk today about vaccine recommendations, some of the recent updates, a quick overview. Any questions, concerns, please ask us, and we could keep it interactive. All right.
So with this topic, this is a good thing to go over every couple years or even more frequently than that because they make changes to the recommendations for the vaccines. And then it's really good to stay updated on it because sometimes those recommendations can really impact patients, such as the zoster vaccine or the hepatitis B recommendations we're going to talk about. Those can make a big deal for the patients that it impacts. So we'll go ahead and see.
So some of the major objectives we want to cover, and also some of these slides are from our colleague, Dr. Marv Bittner. So I wanted to let you all know that too. So make recommendations for vaccines for adults that reflects the update in the past 2 years from CDC. Explain the distinctive characteristics of the new hepatitis vaccine. And also rational for the new pneumococcal vaccine. It's been so confusing with the pneumococcal vaccine in the past, I don't know, 7, 8 years.
Yes.
We have a simpler recommendation, so we'll talk about that.
So here, when it comes to hepatitis B, there are going to be a couple things that we talk about. Let's see now. This is again the hepatitis B and then pneumococcal, zoster, rabies, COVID, and monkeypox
And influenza.
and influenza.
So Hep B, as healthcare workers, we all have to be vaccinated. And we also know there's 10% of us are called non-responders. There's some data on like, is it genetics? Is it where we get the vaccine shot, gluteal versus do we store it appropriately? Do patients with diseases like chronic kidney disease, immunocompromised disease, is that why they don't get, they don't respond to hepatitis B? But do they actually respond, but the titers fall? So lots of different scenarios. We still don't have an answer, but there are some folks that don't respond. And in my personal view, anyways, if that happens, sometimes for healthcare workers, we do the series again to see. Even sometimes if they don't respond, you still consider them immune because they have gotten series, and it's not like you keep vaccinating them, but we all know there are certain population that doesn't respond.
Yeah, and when we say not respond, what we mean is they get the vaccine and then they check the antibody response and it didn't go up as high as you wanted. So there's certain cutoffs where they say they responded and they didn't respond. And so some of those patients may be okay, as you said.
Yeah.
They may still be immunized,
Protected.
protected,
Yeah.
but they just, they didn't like their antibody levels didn't come up like we wanted, but if they still may be protected. So what to do with those people? There's no FDA approved I think response to what to do with
Yeah.
those. So some people give the vaccine over and over and then keep checking to see if they responded. But there are kind of different, or some people try a different vaccine.
Yeah.
They do kind of different ways.
So, for hepatitis B, there is East recombinant reimmunization. So, you could try when you're trying to reimmunize those 10, you could do extensive, you could try all these three different vaccines. Energix, it's 0, 1, and 6 months for vaccine. So 0, 1 month, 6 months. Recombinant vaccine for dialysis patient, you could do 0, 1, and 6 months. Or Twinrix, which has Hep A and Hep B, again, 0, 1, and 6 months. And I like the Twinrix because it also has the benefit of Hep A too.
Yeah, and if they're going to both get Hep A vaccination and Hep B, then it's easier just to give it, in one. So it's fewer shots overall.
But
Oh, and then this is a adjuvant hepatitis B vaccine. So generally, the ones that have the adjuvants are a more powerful response generally, but also means a more local reaction. So if you have a localized reaction, so what does that mean? So when people get a shot, they can have, usually it's a pain from getting a shot, a localized redness, and usually that's about it. Some people feel a bit of fatigue, some people get a headache, but when they talk about shots and how big are the reactions, it's normal to have pain at the site from getting a vaccine and a little bit of redness. But sometimes if your body responds more to it, like the ones here, you might have a bigger response.
Yeah, and this name of the vaccine, this one is approved for 18 years and older. It's a newer one, Heplisave-B. A lot of interesting names, but that's what it's called, Heplisave-B. All right.
Helpless save, maybe they're trying to save you.
Yeah.
Yeah. And this is a 2-dose schedule, so 0 and 1 month. So, the pharmacy company here is trying to really promote, look, you don't need the patient doesn't have to come in 3 times for the shot. They can just come in twice because, patients not coming in for a third shot can sometimes be an issue, but the fewer shots that you can protect someone, the better. And here it was approved for 18 years and older, but it's just a 2-shot vaccine here.
And then you have Preherbivol. It's a 3-shot vaccine for hepatitis B. And it's 3 antigen, not 1. So it has different mechanism of trying to stimulate it to have antibodies. They're made from Chinese hamster ovary cells, not yeast cells. So they're trying a different mechanism. Also a newer vaccine, approved for 18 years and older. And 3 doses again over 6-month period, 0, 1, and 6. So these are all different types that you could try, especially those folks, that 10% that are not responding, immunocompromised, dialysis patients, sometimes are healthcare workers. And I really like this graph.
And then as for this is essentially looking at, who has hepatitis B. And if you look at it, this is going by age groups.
And from 2004 to 2018 and over. So they have been trending hepatitis B infection. And if you all see, once hepatitis B vaccine it's become mandatory for children at birth. But also with the awareness, the infection rate has slowly trended down.
Mhm.
But if you still look at 2019, it's wonderful when you see the 0 to 19 years of age, very little hepatitis B at all. But if you look at the other population, it's still there, but highest is if you're 30 and older or 40 and older. And, I would say hepatitis B vaccine is one of those vaccines that prevent cancer because hepatitis causes liver cancer. So it's an amazing vaccine. We should be promoting, giving it to everyone. So that's how I always talk about hepatitis B. There's a couple of vaccine prevents cancers, Hep B, and also HPV vaccine.
And the updated recommendations, they changed who it's recommended for 19 and older because as children, the babies have been getting it for a while now, but when you're thinking about 19 years and older, it's now recommended for those groups, I think, independent of any of the risk factors, right? So it's really saying everybody should get this vaccine, which I think is a great idea.
Yeah, and when patient comes to our infectious disease clinic, even for many things, we always ask about vaccines and try to catch them up on their hepatitis, pneumococcal, shingles. So it's really important not to miss an opportunity to vaccinate our patients.
So the new universal hepatitis B recommendation. So it was previously based on risk factors for adults. So, when you're seeing a patient, you're supposed to look at their risk factors and then say, are they at risk for hepatitis B? And so you might look at, what is their sexual exposure? Are they at risk for blood exposure? What do they do for work? And then some international travelers. So generally with international travel, if you're going to be spending a long time, like I think they say 6 months or more in a country that has higher rates of hepatitis B, then think about vaccinating those travelers. And part of it is if they're in that country and then they get into a car accident and they get a blood transfusion, and car accidents are the main risk of death, when people travel, that's the number one would be car accidents. And then if they were at risk, because they're going to be there a long time.
Yeah.
But now it's just everybody.
Yeah, we have a travel clinic, so we make sure all our patients are up to date. But exactly, especially when you travel, you don't know what kind of sterile equipment, blood exposure. So it's really important to make sure all our patients are up to date. But yeah, now it's like birth at time of birth, anybody over the age of 19, anybody over the age of 60. So we just need to catch up, folks. And if anybody wants vaccine, we should give the patients vaccine for hepatitis B.
Yeah, and as you can tell, we're very pro-vaccine.
Yeah.
So the more things you can prevent,
Yes.
it's better to try and prevent rather than deal with it afterwards.
So we'll ask you all a question. So it's changing our topic to a different vaccine. So if you have a 65-year-old non-smoker, healthy patient, no previous pneumococcal vaccine, so they're just coming into our health system for the first time, do you give them PPSV 23, pneumococcal 23? Do you give them PCV 13? Do you give, based on shared decision making, you either give 23, 13, or you do 23 follow-up in a year? Or do we now recommend PCV 20? What do you all think? You could unmute or like put it in the chat. What is the new? Yes.
Oh, we have
Kelsey, thank you. Yes, so a new recommendation is that we give PCV 20, and we're going to talk about why. Why is PCV 20 superior than 23, 13, and other pneumococcal vaccine?
So here we have a picture, and you can see from the picture, we're looking at a couple things here. All the way on the left, you have the capsule, and then you have polysaccharide, or you have a conjugate and a protein conjugate. So, these are different ways of giving a vaccine. So it's either a capsule or a polysaccharide or a conjugate, like a protein conjugated vaccine.
So if you look at it, for example, the PCV 23, it was trying to induce immunity through the polysaccharides. But PCV 20, it's trying to induce immunity through the protein component. So there's two different mechanisms for these vaccines, and one is better than the other. So now on the next slide, we'll tell you all why that is. So when they did the study and they looked at when you have pneumococcal vaccine, if it targets the polysaccharide or the protein, which gives you a better immune response. So anytime you had a pneumococcal vaccine that targeted the carrier protein and it's conjugated, it was T cell dependent, memory B cell production, and reduced pneumococcal carriage. So that's fantastic. So it produced more immunity. And also when people are like carrying pneumococcal, because a lot of people have just a colonized, right? It reduced that. But when you did it, when you used a vaccine that was just polysaccharide base, and not the protein base, they only were they were T cell independent, but no B cell or reducing carriage. So, B cell produces memory in our immune system, so you have better memory, so you have better response. So overall, if you have a pneumococcal vaccine that is protein based, you had a better response. Hence the new recommendation. So here's, again, it's a really nice way of looking at the CDC recommendations. So you have PCV 13, it's a protein base, but it only covered 13 different strains. PCV 15, you got up to about 15 strains. The 13, 15 actually talks about how many strains. Did you all know that pneumococcus have over 100 strains, but these are the most common ones that cause infection. And then if you look at PCV 20, now you went up to 20 strains, and it reproduced B cell memory, and also carrier state went down. But if you look at the 23 PPSV 23, even though it hit more strains, it didn't induce B cell memory, T cell memory, or had decreased carrier overall. So that's one of the big reasons they have recommended we go with PCV 20, because better induction, better response, and less carriage for a pneumococcal.
Yeah, I mean, and I think simplifying it has its huge benefits as well.
Yes. Oh,
But
yeah.
yeah,
Everybody was confused. Do I give 23
yeah.
first, 13 first? What do I do if I give, oh, it was a mess for a while.
And reducing carriers, I think, is a big deal also, because if you can reduce someone from being a carrier, then you can reduce the spread and everything.
And also let them getting the infection later on too. Yeah.
Yeah, and so with strep pneumoniae, so if you can get it and then you can get it again, and people will say, well, how can I get it again if I haven't been vaccinated? And this is exactly what Dr. V is saying, that there are different strains, and you may have an antibody to one strain, but because there are so many, ideally you'd benefit from getting a vaccine to as many strains, and really the most common strains is really what you want
Yeah.
overall.
You know, pneumococcal is when my patients get
Yeah.
pneumococcal infection, it's bad. Like, you don't see endocarditis as much, but I have patients that I'm taking care of who have had severe pneumococcal bacteremia, pneumonia, endocarditis, and septic emboli to the brain. So it's a no joke. It's bad infection, and we need to be making sure people are vaccinated.
Yeah, and this is something we try and stress to when we're teaching to the medical students or residents or fellows. We try to stress that this is bad, because
Yeah.
sometimes we'll get some learners that'll say, "Well, I thought this just gave you pneumonia,"
Yeah.
right? And I think that's what you're getting at. It's
Yeah.
like it does give you pneumonia, but it can also kill people and be very bad.
Can I give a little pearl? So, if anybody has in your hospital pneumococcal infection, know that there are new data that shows when you use the beta-lactam, if you give them azithromycin for 3 days, it decreases their overall mortality. So you treat them with, ceftriaxone, but if you give them 3 days of azithro, it overall decreases mortality. We'll talk about in a webinar, just planting that seed.
Yeah,
All right.
so if you're bacteremic with strep pneumonia in the blood and it's susceptible to everything, but if the patient's extremely sick, you would dual cover.
Yeah.
You give 2 antibiotics for the same thing.
So we'll talk about it. We'll make it a next webinar topic, but know about the azithro. Okay. So who should be getting pneumococcal vaccine?
So there are a lot of indications for the vaccine, and if you look it up, there'll be large charts, and it'll go by organ system, and it'll have a check mark next to all the indications. And the one of the infectious disease doctors that we work with goes by organ system, and he'll just go by organ system just as this is, and it'll say it'll start with the heart. Do they have chronic heart disease? And then the lung, do they have lung disease? Are they a cigarette smoker? Do they have liver disease? Alcohol abuse? He'll point to his pancreas and say, do they have pancreatic disease? Same with diabetes, pancreas. And just, because there's so many indications that it's hard to keep them all straight.
And then remember, like when people, let's say you have a 50-year-old that comes in and they have diabetes, they should get pneumococcal. Let's say they're 50 and they come in with alcohol abuse, they should get pneumococcal, because they are all high risk. Because what we have known, and everybody thinks is like 65 and older, but even if you're young, if you have these conditions, you should get pneumococcal vaccine. And of course, if you have CSF leak and cochlear implants, you should get pneumococcal vaccine as
Yeah,
well.
people that have had head trauma in the past, if they've had skull fracture or something in the past, then I would consider giving it to them also. Yeah, cochlear implants.
And then, of course, immunocompromised condition. I'm taking care of a patient currently who was immunocompromised and severely ill with pneumococcal. So renal failure, nephrotic syndrome, asplenic, and then, of course, all the different types of cancers as well.
Yeah, so I would have a really low threshold, to consider a patient, for this.
If you're already given 23, should we revaccinate with 20? Yeah, we're going to get to that. We'll get to that. Very good question.
And then additional immune deficiency or suppression. So additional conditions that would put you at risk, and something that if you had any patients with any of these, really have a very low threshold to give it, because there's so many indications.
Transplant, immune deficiency, HIV, everybody should be getting pneumococcal. So here's the new recommendation. So hopefully this will answer the question, Marvi. So it says that if you have gotten 23 before for chronic medical condition, CSF leak, cochlear implant, immunocompromised conditions, you could now just do PCV 20. So that's the previous recommendation now if you could do this. But if they already gotten 23 and they haven't gotten PCV 13, then I would still give them PCV 20. So I would give them PCV 20 if they haven't gotten 13 and just 23, I hope that answers your question.
And then for adults 65 years and older, again, you would consider giving them PVC 20.
Yeah.
And then in the past, they had other recommendations and they got pretty complicated. And then they had to, I think they came out with recommendations and then they had to try and simplify it because it's too much to remember everything. But
And the other thing I would say is that, let's say your patient that you're just asking about, they have given 23 before. Either you could give 20 or you could give them, like it says in the box, you could give them PCV 15. Then at least you're giving a protein-based pneumococcal vaccine, which induces more immunity. So I would give some sort of PCV, but if I can, I'd probably give that patient 20 again.
And then this is adults 65 and older or 19 to 64 with risk factors. And those are all the risk factors that we discussed, that long list. So if they had previous PCV or unknown history of pneumococcal vaccine, and just to simplify it, you can give PCV 20. And then if they've received 23 in the past, you can still give PCV 20. So I try to simplify it as much as possible, just so you can quickly give people recommendations and without trying to look it up every single time.
Yeah, so I would say the best answer now is just giving PCV 20 for all our patients, 19 and older, and also making sure we know all those risk factors. One other risk factor I would say is if you have a patient who recently had pneumococcal infection, they should eventually get in the near future vaccine again because they're high risk already, proven it. Even if they're 40 and they got pneumococcal vaccine, they should probably get pneumococcal infection, they should get the vaccine.
That's a really good point. So people will say, should I get it? I've already had the disease, but as we were discussing all the different types, then yes, they should get it to try and prevent one of the other types. Yeah, that's really, really good point.
And then CDC has this on their website. It's called Pneumorex. It's called Vax Advisor, and it's an app. So like it also really helps you with understanding pneumococcal vaccine, when to give, who to give. So it's a really nice tool to use it. You could download and use it from CDC.
And then here's a question, because we all love doing questions together. 65-year-old non-smoker, healthy, no previous pneumococcal vaccine. Oh, and the answer is already there for everybody. So PCV 20. So, and these are the old recommendations versus the new recommendation. This is a 7-year-old in good health, childhood egg allergy. So we're switching topics here.
Yeah, transitioning to a different vaccine.
So we're gonna start talking about influenza vaccine. So childhood egg allergy. Now they eat scrambled eggs, okay. And it's saying that because some people that eat scrambled eggs will have allergy to egg, and then they have kind of a higher allergy. So okay, with a standard dose quadrivalent influenza vaccine, which quadrivalent seasonal flu vaccine would you give?
So, apparently they have egg allergy, but they eat okay. And out of all these options, you could put more than one option, but in this case, all these 3 answers for this patient is right. You could give Flublok, quad,
yeah.
and Fluzone high dose. And we're going to talk about a little bit about older population and what kind of vaccines now, and also about egg allergy.
So the current flu vaccines, so they're all quadrivalent, 2 A strains and 2 B strains. And the strains are typically the strains are chosen in February for a season beginning typically 9 months later.
And usually my indication is I look at Australia and stuff, what kind of flu they're, because they start early and I could kind of predict what's going to be here. And that's, I was looking at earlier, like it's going to be, type A, and we had a lot of type A. So usually it follows the trend in the other coast. And then of course for live vaccines, live vaccinated influenza vaccine, for 2 to 49 years of age without any chronic conditions.
So special populations are immune compromised and egg allergy. So immune compromised, you want to avoid the live vaccine because you don't want to actually get them sick with it. And there's little data on high dose, looking at high dose versus standard dose. So we'll talk a little bit more about high dose in a minute. And then for egg allergy people,
According to CDC, not FDA label, and not a general contraindication, severe reaction history to vaccine in healthcare setting, ready to treat emergency. So like I would say if you have severe allergy, if they're really worried, just vaccinate them in the healthcare setting and watch them for 15 minutes.
yeah, and I think that's where it comes in. If you can eat eggs and you can tolerate eggs okay, then
Yeah.
it's okay to give
It's
them a
okay.
shot.
Yeah. Allergic reaction to influenza vaccine is contraindicated. So that's not because of egg, but if they had like severe Guillain-Barré or something like that due to influenza, then you shouldn't give it again. And here's the burden of influenza vaccine. As you could see, when you're older population, 65 and older, the burden is hospitalization is 87 to almost 500,000 people. And unfortunately, in our elderly population, death can go up to 17,000. And, respiratory up to 43,000 if you just bulk it all together for, in the winter season. So we're going to focus a little bit about why this population is really important.
So this is influenza in older adults. This is 65 years and older. And this is looking at the season here on the left. And then this is vaccine efficacy and how well the vaccine worked. And if you see the ones in red here, and this is comparing overall vaccine efficacy for comparing with those that are 65 and older.
Yeah, so they got everybody and then 65 and they compared what happens.
So people 65 and older, when they're at increased risk for having bad outcomes, and then also not really responding to the vaccine like people with younger, more healthy immune systems. So what can be done about that, right?
Yeah, like in 2018, for example, overall it was 29%, but when you look at 65, only 12%. Or if you look at 2012, 49%, but in 65 and older, only 26%. So like really you could see the decreased efficacy as we get older.
And now some people will look at this and they'll say, oh, the vaccine isn't very good. It's only 49% effective, but that sounds good
I
to
think
me.
it's really good, yeah.
Because it's the best thing we can do to prevent flu is taking the vaccine. And if you tell me it's 49% effective, that's a good thing.
Even if you get the flu, by having the vaccine, you have less severe disease. So that's important to know as well. Okay.
So higher dose and adjuvant flu vaccines. So high dose influenza vaccine, there's Fluzone high dose, and then adjuvant, there's influenza vaccine, and then recombinant. So when we're talking about adults, they look at higher dose and the adjuvant versus something else, right?
So benefits among studies comparing high dose adjuvant vaccine with one other, evidence is insufficient to inform recommendation of any one over the other. Among studies providing safety data for these comparisons, no results favoring any vaccines of the selected critical outcomes. Overall, certainly low, primarily due to impression stemming from low events counts for small samples. So they say in elderly population, like one is not better than the other, but we'll get to the next slide.
And these small sample sizes, so sometimes it makes a difference. And in the study, you can say it made a difference, but it wasn't statistically significant, probably because of the low sample size.
So what they recommend is either one of these three vaccines are okay for if you're over the age of 65. And if none of these three vaccines is available, any age appropriate vaccine may be used. So again, you could use the flu quad, flu block, or high dose. So all three different types of vaccine in elderly patients. These three are not available. You could still use the regular influenza vaccine. So that is what currently recommended. For example, certain hospitals, they carry high dose, like depends on your formulary, what you buy each year. But overall, any three of these might be much better than the regular vaccines.
And now we have a 30-year-old woman on methotrexate and Humira for rheumatoid arthritis. And now we're going to talk about zoster vaccine. So, would you give something for zoster in a patient that's immunosuppressed?
So, what do you all think? Is it A, B, C, or D? For this 30-year-old, would you give them zoster vaccine? Love to see some response.
And the zoster vaccine, this is one that has some updates, and that's why
Yeah.
we want to talk about zoster because this
Okay.
this is one that's one of the ones that's like the others is very good
Yeah.
to talk about with a
All
new
right, we'll
update.
show you the answer.
Oh. So Shingrix. So this is a good one, if your facilities, to check, do you have Shingrix? Is that the one that you're giving? And
Yeah, the nice thing about, so that patient was immunocompromised. She's young. So a lot of people would think, oh, you don't need zoster in a 30-year-old. But
mhm.
Shingrix you could give now because it's not a live vaccine. So that's important to know. You could give Shingrix in immunocompromised folks because it's not live. And here's some data.
Yeah, in the past they would say you can't give a live vaccine to someone that's immunosuppressed, or you might give them problems essentially. But this is one of the good update is that now we have something that's not a live vaccine that people can get. And this data is looking at let's see,
Hematopoietic stem cell
stem
transplant,
cell.
so if you look at, you want it in the bottom, the incidence, right? 0, it goes up. But those patients are really at high risk for getting shingles. And then, of course, you have the hematopoietic malignancy, they're high, solid organ, they're high, HIV patient, they're high. And even in the last column, if you look here, as you 50 and older, the older you get, even though your immune system is working really well, you still get shingles. I've been recently seeing a lot of shingle patients, and especially in elderly patients, and they don't have any immunocompromised conditions. It's like diffuse disseminated shingles, and this can really work. So it's really important for us to think about Shingrix, which is a non-live shingles vaccine that we should be vaccinating our patients with.
And zoster vaccine in immune compromise. So the efficacy is pretty good. And then one of the goals of giving this vaccine is to prevent post-herpetic neuralgia. So zoster can be extremely painful. And when they looked at what age they recommended it for, they would look and they would say, you know, the older population is at most risk for post-herpetic neuralgia. So that's when they get zoster, it's painful, and some people can have that pain persist for months or years afterwards. So when they looked at, they said, what is the goal of the vaccine? And they placed a very high uh, importance on preventing the pain of zoster. And so if in the past they were looking at what age to give it at, so if they give it at 50, that's good. It'll prevent you from getting zoster for a while and also help with the pain. It'll shorten the duration and then also shorten the pain or decrease the pain of zoster. But the people most at risk are the older population that are 65 and older and 70. So when you look at when to give them the vaccine, some groups would say younger, like 50, and some would say well, a little bit older, and that way you can help prevent them from getting post-herpetic neuralgia.
Yeah, I would say yes, definitely 50 and older.
Yeah.
And all these immunocompromised patients,
Yeah.
even if they're young,
Yes, that's
now
right.
they should be getting it because we just showed that graph with really high rates. So if you have a 20-year-old with an organ transplant, if you have a
Yeah.
30-year-old on Humira for her Crohn's disease, really any type of bad immunosuppressive
Yes. Yeah.
patients, we should be giving Shingrix to prevent shingles.
Yes. Yeah.
And it's kind of exciting because this just happened the last like 5 years or so. Before that,
Oh,
a
yeah.
lot of my patients who are immunosuppressed, we would say we can't give it to you
Yeah.
because it's a live vaccine.
Yeah. And now they can get it, so it can. So we have more ways to prevent zoster and
Yeah.
prevent pain in our patients. Yeah.
So it's usually two recombinant zoster vaccine in immune compromised population, 2 dose for prevention of zoster. Anybody, zoster related to complication, immunodeficiency or immunocompromised adults greater than 19 years of age.
And then we're going to shift gears and talk about rabies. So there's pre-exposure prophylaxis and post-exposure prophylaxis. So pre-exposure, when you're thinking about preventing, giving people a vaccine before they've been exposed, so preventing it in populations that have a high rate of being exposed to rabies. So these are veterinarians, spelunkers, people that go in cave and are going to be around bats, or certain travelers. And when people travel, sometimes there are dogs, just free roaming dogs in the country, and they're at risk from being bitten from those dogs because some countries have a lot of dogs wandering around the streets.
Yeah, and what we used to do is like vaccinate these folks at 0 days, 7 days, and 21 to 28 days. But new updates is that if they're going to be high-risk patients who need rabies vaccine, you could just give them 2 at 0 and 7, which is fantastic instead of doing 3 doses.
And in those countries, also people that are runners. So if someone goes to a country that has dogs around and they run, they're at risk from being chased or bitten, or children if they can't tell you they were bitten by a dog or something. But this is a very good update where you only need 2 shots. And then post-exposure.
Yeah, so like we get a lot of calls. So
Yeah.
like post-exposure, a lot of the calls we get is like, I woke up, I have a bat in my room, my child had a bat in my room. Bats are really high risk for carrying rabies. You should get the bat caught and the Humane Society can't test it, but unfortunately if you don't and the bat has escaped or they cannot test it, what if you woke up and saw, you don't know if the bat saliva got into you, if they scratched you, you have to give rabies post-exposure prophylaxis. So you do immunoglobulins and you have to do the vaccine at 0, 3, 7, and 14 days. So this is 4 different vaccines that hasn't really changed, 4 vaccines and immunoglobulin. We get these calls a lot. I'm sure some of you all do too. So just something to remember. And of course, if you get bitten by stray animals and stuff like that, you do this. But most calls that we get is about bats in the house.
Yeah, so I wouldn't, I would use gloves or not try and grab a bat with your hands or something like that, because we've had that before where people, or they're, messing around with a bat that they found or something. And
just be very careful. And I always say when people ask me, should I'm like, it's better to be safe than sorry.
Yeah.
Because like if you get rabies, you die. But there's a prevention. So please, so my recommendation always is get the immunoglobulin, get the vaccine.
Yeah, once you're showing symptoms of rabies,
there's no cure.
It's over.
Yeah.
And then COVID. So you have a couple updates with COVID.
Johnson & Johnson no longer available in US, but I'm sure you all have seen Norvax is available, and some patients might really like this compared to the RNA vaccine because it's a different method. It's a recombinant protein subunit vaccine 2-dose series. So just wanted to quickly update if you have this vaccine and offering this vaccine, CDC currently has it part of their schedule. And what they say is that if they're unvaccinated, they need 2 doses of Novax. But if they're already vaccinated with something else and you just need it as a booster, they just need 1 dose of Novax. So it's pretty easy. If your patient wants Novax as your COVID vaccine, they could get 1 dose of this as a booster. If they've never been vaccinated, they need 2 doses.
And then the Jynneos. So now we're moving on to monkeypox.
Yes.
And this was originally for smallpox vaccine. So it's a approved dose, and you get 2 doses 4 weeks apart. And it was originally for smallpox, but it's being used for monkeypox and works for monkeypox as well.
We did a webinar on this long time ago, but just a reminder, it's available now for high-risk population, healthcare workers who are, taking care of monkeypox. We haven't had any case, but just a reminder. It used to be that you did intramuscular, but then intradermal worked just as well. So you could do more doses with 1 vial compared to just 1 dose. So this is also available currently. I'm actually vaccinated for
Yeah.
monkeypox.
Yep, I had a monkeypox patient.
Yeah.
Yeah. And then 10 take-home points. So we discussed hepatitis B, and the adjuvant only has two doses, and 3 antigen may also help with non-responders.
And Hep B is universal. Everybody should get vaccinated from birth, any 19 and 59 years, any high risk factor. Pneumococcal, very simple. Everybody,
Mhm.
PCV 20 for all the high risk folks we talked about.
And then influenza, higher dose and adjuvant vaccines are preferred if you're 65 and older. It's preferred, although the CDC makes no specific recommendation and the ACIP make no specific recommendation for it. But if you look at the data, it looks like it really helps. Yep.
And immunocompromised for zoster, you could give the new
Shingrix.
Shingrix,
Yeah.
yes,
Yeah.
vaccine. And we should be giving it to immunocompromised patients and also 50 and older.
And then pre-exposure for rabies. So if you're going to if someone comes and they say that they're high risk of being exposed to rabies, then you would give them 2 shots on day 0 and then a week later.
And Johnson no longer available because of clotting, but Novavax COVID vaccine is available. It's still protein subunit, not a lot of issues. Booster with 1. If you're starting from new, they never had vaccine 2 doses.
And then monkeypox, the Jynneos, you can give it intradermal now is the new change.
And 2 doses.
And 2 dose, yes.
And that's our take-home point. And thank you, Dr. Bittner. He's one of our infectious disease colleagues who gave the slides to us.
And we were able to adapt them
Yeah.
for specifically for what you all are interested in. And then, are there any questions at all?
That's a quick review, but if you have any questions, we're happy to answer any questions.
Yes, and we're always available. So everyone that we work with, you know that you can call us anytime, and we're always available to answer any questions. If you have any specific questions, you can always email us, and we can send you any information. And happy to discuss any specific cases that you have.
Yeah, and Samaya will be presenting next next month and the month after. She's going to talk about the NHSN requirements for stewardship and get into a little bit of those details. So we could cover those as well. So thank you so much.
All right, thank you, everybody.